Now let's go on with our next speaker, Professor Satish Nesri. Professor Nesri, please connect your talk.
Yes. Good evening, everybody. I'm Dr. Satish Nesri. So I thank Asami India team for giving me opportunity to talk on corticotomy. So I'll be talking on definition, types, techniques, regenerate, problems of corticotomy, poor regenerate and its management, and some cases are done by me. So before starting, I would like to emphasize that stable fixation is a must before going for a corticotomy. And we all know distraction causes distraction osteogenesis. But compression does not always produce osteogenesis because if the fragment fixation is not proper, or you are compressing in a shear force or a displaced fragment, this can lead to a necrosis of the bone fragments and resorption of the bone. So compression does not always produce osteogenesis. And again, the osteogenesis depends upon the compressive load given and state of blood supply and quality of fixation. So corticotomy, also known as compactotomy, by definition, it is a cortical osteotomy with transection of the bone cortex, preserving periosteum and endosteum. And we also should know that there is something known as latency period. It's a period of time after corticotomy and starting of the distraction. So coming to the corticotomy types, transverse and longitudinal osteotomy, we have two types. And in transverse osteotomy, we have classical method, which has been mentioned in all the Lizaro books, and multiple drill holes technique and a jiggly saw method. So as I said, stable frame is a prerequisite before proceeding to the corticotomy. So in classical method, after applying a stable fixator, the distraction, the connecting rods should be removed, and an incision is made on the shin of the tibia, and periosteum is elevated all around that is the lateral surface and the anteromedial surface of the proximal tibia, as is shown in the figure. The 5 mm or a 10 mm osteotome is taken, and you can see here only the cortex has been severed. So similarly, the anteromedial surface is also the periosteum is elevated, and corticotomy is used, and cortex is severed. And in this last right lower picture, you can see the hexagonal shaft of the osteotome. We use a 13 mm spanner and fix it onto the shaft of the osteotome and rotate in clockwise or anti-clockwise manner in order to disrupt the discontinuity of the cortex. So in this lateral view, you can see the osteotome has been rotated in order to weaken the posterior cortex. Once you have weakened the posterior cortex, both the proximal and the distal segment is held with the hand, and external rotation osteoclasis is done in order to break the posterior cortex. So in jiggly saw method, we have used a jiggly saw. We usually use a jiggly saw, which we usually use for amputation. So here an anterior incision is made over the shin, and another incision on the posteromedial aspect of the tibia. And jiggly saw is inserted as shown in this picture, and gradually with saline pouring, the jiggly saw osteotomy is done. So we have a multiple drill holes method, which is commonly used, and I have learned it from my mentors. So here what we do, initial drill hole is made on the outer cortex. With the single drill hole with the multiple direction, the opposite cortex is weakened with multiple drill holes. And similar to 1 or 2 or 3 entry points are made, and the opposite cortex is weakened. With the help of an osteotome, we just connect the whatever drill holes we have made. We just connect them under the C-arm guidance. So this is one of the patient I have recorded. A 2 centimeter small incision is made. There is no periosteum stripping, only the muscles is separated. And we use, I personally use a 4.2 drill bit. And then under the C-arm guidance, I do an initial drill hole, and then with multiple directions, I weaken the opposite cortex, as it is shown. You can see here I'm holding a saline soaked gauze piece. This will help me to stabilize the drill bit and avoids inadvertent piercing of the opposite cortex. So always you have to hold the drill bits firmly and drill the holes, not injuring the neurovascular structures. Now, with the help of a 5 mm or a 10 mm osteotome, I just connect the multiple drill holes which I have made. This has to be constantly monitored under C-arm just to prevent inadvertent piercing of the opposite cortex. You can see a nice linear corticotomy has been done. So how to confirm whether the osteotomy is complete or no? So here I have loosened the outer side of the nut, around 3 to 4 mm I have loosened, and then I'll ask my assistant to gradually give a distraction force, as you can see here. And once after this, I take a C-arm shoot and just see in the C-arm. So here you can see a nice distraction has been occurred, which indicate that my osteotomy is complete. So what is the basis? This is a preparation for a good regenerate to obtain. So osteogenic activity of a connective tissue is stimulated by tension stress when tissue is stabilized. So again, I am emphasizing stabilization of the frame is very important. So quality of new bone formed depends upon distraction force, cross-sectional area of the distracted region, rate and rhythm. And at the end of distraction, once you have obtained adequate distraction, once you stop, the connective tissue is automatically replaced by a good bone. For a successful regeneration of a bone to occur, axial loading of bone, that is, patient has to walk, and a good blood supply and good muscle activities required. So conventionally, in all the books we read, rate of distraction is 1 mm per day, and 4 times frequency of distraction is applied, and a latent period is 1 week. This is to allow recanalization and revascularization of injured bone marrow vessels, which is done during the corticotomy. So coming to the blood flow in the bone, which this is very important as far as corticotomy is considered. We have in a bone, we have centripetal blood flow, where the blood enters the bone from the periosteum vessels and comes out from the nutrient vein. Whereas in centrifugal flow, blood enters the nutrient artery, bone through the nutrient artery and comes out from the periosteal venules. So when we do a periosteal stripping, this divides blood supply to the outer third of the cortex. So when we do an osteotomy, suppose if we damage the nutrient artery, it divides the inner 2/3 of the cortex. So always, we have to, while doing a corticotomy, avoid damage to the nutrient artery and avoid extensive periosteal stripping. So when we do a corticotomy, there is some damage to the periosteum as well as endosteum. So how this is compensated by increase in metaphyseal blood supply by means of whatever we have seen, centripetal and centrifugal blood flow. So there is increase in metaphyseal blood vessels and the blood supply is restored. So to obtain a good regenerate, less damage to periosteum and bone marrow, and less comminution. If at all comminution occur, it should not be displaced too much. So this is the crux to get a good regenerate. So an ideal osteotomy is a long oblique osteotomy, should be in the metaphysis without comminution and should be a closed osteotomy. Why it is done in metaphysis? Because the bone is wide and cancellous, wide cross-sectional area, nutrient artery can be preserved, and origin and insertion of muscles already have been adapted for extremity growth. So when to avoid corticotomy? So avoid in old scars, and whenever there is infection, you can wait for a week, 10 days or a month. So not, and to avoid the corticotomy in zone of sclerosis and severe osteoporosis, and whenever there is cyst formation, you should avoid a corticotomy. So what type of regenerate we can get? We can get a normotropic regeneration, hypertrophic regeneration, and a hypotropic regeneration. So there are so many factors which affect a good regenerate. Patient factors, local factors, technical factors, and biomechanical factors. Some of the factors are under our surgeon control, and some of them are out of our control. So coming to the cases, this patient presented to me with osteomyelitis, growth arrest in a 16-year-old boy with 15 centimeter shortening of the right femur. So for this patient, since there was an infection running on, first process was control of the infection and second is the union. So once in 2 months, everything got controlled, fracture united, the non-union united. So I proceeded with the lengthening process. So I could achieve a good 12.5 centimeters regenerate. And here you can see the bone, the limb length has been discrimination that is equalized. So this is at the end of 13 months, the bone has nicely united and the patient is walking nicely and is back to his college. This is another case with a 4 centimeter defect which occurred following a debridement of an open fracture where the surgeon has treated with plate and screws. There was necrosis of the skin and infection was there. So I had to excise the 4 centimeter dead bone. And since there was a little persistent infection, I waited for corticotomy for about 10 to 12 days. And then later, once it was confirmed that infection was absent, then I did a corticotomy. And as you can see, early weight bearing, axial loading, muscle action, and a good blood supply is a key to get a good regenerate. And this patient immediately started weight bearing, and patient had a stable, painless frame. So this is at the end of 5 months, the fracture united, a good regenerate was consolidated, and he's a priest in a temple and he is back to his work now. This is another patient in a polio limb. The patient had a osteomyelitis of the tibia, and in this patient, I had to excise the necrosed bone and I did a proximal corticotomy. In polio bone, since the musculature is less, we have to wait. The latent period has to be increased, not for 7 days. You may have to wait for 10 days or 12 days. And then start the rhythm also we have to slow down, maybe 0.25 mm BD or TID, and then gradually start the distraction. So this is at the end of 6 months, a good regenerate was obtained and the bone nicely healed. And this is how the patient comfortably walking with painless, near normal gait. So this is another patient where I did a bifocal, very long bone transport. This patient had a comminuted type 3C fracture with multiple fragments. So I had to excise the necrotic bone fragments. And here you can see I did a distal corticotomy because there was no place proximally. So distal tibia is a very interesting area. As we know, there is a less blood supply. Why there is less blood supply? If you see the nutrient artery supply to the tibia, it enters into the diaphysis through the middle of the bone and divides into only one descending and two ascending arteries, as you can see in this picture. So only one nutrient vessel in the lower third of tibia, less periosteal blood supply, and decreased muscle bulk. These all factors helps means the infection and non-union are more common. So in such cases, when you do a lower tibia osteotomy, you have to increase the latent period from 7 to 10 days and also decrease the rate and rhythm of distraction accordingly. So in this patient, I started with a 0.25 millimeter twice a day. And then as I saw the good regenerate, I increased it to 4 times. And then at the end of, so at the docking side, there was a problem with skin invagination, which I dealt with the excision of the skin and added a little bone graft. At the end of 15 months, I could get a good 16 centimeters long, good quality regenerate. And so another patient, trifocal bone transport has been done. Plastic surgeon did a flap. Sometimes flap interferes with our work. So this patient, the surgeon did a flap surgery, but the bone ends were not proper and were unhealthy in the X-ray. So I had to excise the bone graft, bone ends. So it came to about 5 inches of shortening after debridement. Then I did a trifocal bone transport by Elizaro, did a 2 osteotomy, 1 above and 2 below. In between, he had some infection. I had to exchange wires and add a stimulant antibiotic beads at the docking site. So this is very important because always stability of the frame is very important to get a good regenerate. So if you come across any infected wires, never hesitate to replace them. So this is at the end of 11 months, a good regenerate has been formed and union has been achieved and patient is back to his agriculture work. Another patient, trifocal bone transport has been done. Patient had a polytrauma with head injury and patient had subdural hematoma for which craniotomy had been done. So in this process, the tibia was neglected and so tibia went for a necrosis, 18 centimeter necrosis. So I had to excise the 18 centimeter dead bone. By the time the patient presented to me, patient was bedridden and was not able to sit up and very non-compliant patient. I hesitated to apply Elizaro in this patient. Many of the surgeons had advised amputation for him, but his father asked me to salvage the limb. So I proceeded with good hope to salvage the limb. I excised the 18 centimeter dead bone. And here you can see the distal tibia. There is a scar and a wound is there. Never do an osteotomy when such condition is there. Always wait for 10 days, 15 days, 1 month to heal the wound to heal and then go for an osteotomy. So in this patient, I did a trifocal bone transport with 2 osteotomies and gradually distracted. So this is after the completion of the completion of the transport. So in this patient, when I excised the 18 centimeter bone, I did not do any flap. No flap surgery is required. Once I started the corticotomy, wound started shrinking in size. So by the time I could achieve a docking site, there was a good covering of the skin, except there was some raw area, which I did manage by doing a skin grafting. So this is at the end of frame removal, a good regenerate has been obtained and the wound raw area skin grafting was done. In order to protect the regenerate, I gave him a ankle foot orthosis in order to just to protect the regenerate. And corticotomy in a deformity correction is also useful. It is useful in deformity correction also. You can see this patient has a grotesque lower end femur deformity. So I had to plan with a graphical method and then mounted Elizero frame. You can see an oblique osteotomy has been done in the lower end of the femur. The rings were so close, I had little bit difficulty in doing a corticotomy, but I could do a very good work here. And then here 1 mm per day will not work. You have to always use a rule of triangle here. So with this, you have to calculate AD by AB formula. You have to calculate the rate of destruction of the motor rod. So when we calculated it, it came to about 2.85 millimeter. So I had to distract 2 mm 4 times a day in order to prevent premature consolidation. So this is the patient moving after the correction. So longitudinal osteotomy, also known as TTT, as said by Bari sir. So here we do a osteotomy on the anteromedial aspect of the proximal tibia. So by doing this, increase the vascularity of the limb to 300%. Greater the surface of corticotomy, more pronounced is the regenerate. So my way of doing the osteotomy, what my mentor has taught, I make a skin incision, multiple skin incision on the anteromedial aspect, weaken the anteromedial border of the tibia with multiple drill holes, and then with the help of osteotomes, 4 to 5 osteotomes, I just connect the multiple drill holes in this manner, as you can see here. The osteotomes have been inserted into the drill holes, and like a flap, I just break the bone, which has to be confirmed under the C-arm, and then the broken flap is fixed with the multiple K wires, cross K wires like this, and then gradually distracted. So this is a patient with presented to me with gangrene right toe, with a TAO and block at the popliteal artery level. For this patient, I did a longitudinal osteotomy and then fixed with multiple TAO. And then at the end of 6 months, you can see a nice healed vascular limb, and a good regenerate has been consolidated. And we can do it for TAO of the upper limb also. This patient presented with me with a gangrene of the thumb and the index finger with block at the brachial artery level. So I did a osteotomy of the ulna and then gradually distracted. So here it's a simple method. We make a multiple drill holes in the ulna and then connect with an osteotome and then fixed with multiple. At the end of 3 months, a good consolidation has occurred. And sometimes premature consolidation is very common in young patients. And so a rate of distraction 1 mm per day will not help. So in this patient presented to me for lengthening and varicization, pelvic supporting osteotomy has been done elsewhere with a plate. So I did it with a LRS, but there was a premature consolidation, and I had to do a repeat corticotomy through the substance of the regenerate. And then this is the picture. I could get a varicization as well as little lengthening of the femur. Sometimes while using the multiple drill method, drill can get broke and get embedded into the medullary cavity. So do not get panic. Do not meddle with the medullary cavity and periosteum much. Do not try to open. Just leave it like that. With minimal intervention, if you can retrieve the broken drill bit, well and good. If you cannot, just leave it like that. This is an example to show that if you leave the drill bit, nothing will happen. A good regenerate has still been able to obtain with even the broken drill bit. So every time we need to reduce the distraction sometimes. So in case of severe pain, you have to reduce the distraction or sometimes stop the distraction. And if you encounter any neurovascular problems or a poor regenerate, you may have to reduce or sometimes stop it. What are the causes for poor regenerate? So decreased mobility of the patient, decreased stability of frame, poor nutrition, and decreased vascularity. These are the main causes. Sometimes if we come across poor regenerate, you can always try a accordion maneuver, 2 cycles, starting with the compression and distraction, 2 cycles you can try in order to get a good regenerate. This is I can say, a failure of mine with a poor regenerate. This is a doctor. Doctors are a very poor patients. He's a homeopathy doctor. He sustained a road traffic accident and sustained femur and tibia fracture. Both were open fracture. You can see here in this X-ray. This is the initial X-ray. He had a necrosis of the lower end of the tibia. So what the surgeon did was did a flap surgery on the necrosed bone. Later, it got infected. Patient underwent multiple surgeries. During this process, the patient went into severe depression. So cross leg flap, something like this, with both the leg in this position for 6 weeks to 2 months, is a torture, mental torture to the patient. With this treatment, patient went for a severe depression and became addicted to the drugs. He is also a known case of hypothyroidism. So there were so many multiple factors involved.
Dr. Nesri,
Yes.
can we please hurry up because we have case presentations also.
Okay.
Okay.
So this patient, I had to excise the necrosed fragment, and in between he had cellulitis. But at the end, because of severe suicidal tendencies, I had to remove the frame. And this is the last picture where there is a poor regenerate and a persistent non-union lower down. So this is another patient. Okay. To conclude, a stable frame is a prerequisite, and a good corticotomy is a celestial weapon in the armamentarium of an orthopedic surgeon and saves you from all kind of problems. Thank you.
Thank you, Dr. Nesri, for showing the wonderful cases and the corticotomy technique. You have quite excellent cases with so much of lengthening. So it's pretty an eye opener. So what can be done with an Elizarov?